Welcome back to Ronnie, I'm Joe B. Today we'll go over a manual therapy technique and a set of exercises that increased my patient's thoracic extension by 10 degrees, resulting into a reduced, rounded shoulder and round back posture. Let's dive in. A bilateral thoracic flexion dysfunction is when the superior and inferior facets are stuck upward and forward. This results to an increase in thoracic kyphosis. The cause of this can be due to pectoralis muscle tightness, faulty rounded shoulder posture in sitting, and mid-back or scapular weakness. This can bring about a chronic, localized dull aching pain on the mid-back. There will also be a presence of rounded shoulders during postural assessment, with limitation of motion seen towards shoulder flexion and thoracic extension. The assessment for a flexed thoracic vertebrae. In this animation, we will assume that it is the T12 that is stuck in flexion. There are two types of tests that determine thoracic asymmetry: the seated thoracic flexion test and the seated thoracic extension test. To make that vertebrae stick out, you need to select the seated thoracic extension test. Patient is in a short sitting position, feet flat on the floor and arms across the shoulders. The therapist will be behind the patient. The lowermost lateral rib number 10 is palpated first by the web space of the therapist's hands. Then the dominant hand thumb will reach across to arrive at the T12 spinous process. From there, the thumbs move one finger breadth laterally to arrive at the transverse processes of T12, which will be the major landmark to palpate to determine the presence of a flexed vertebrae. The patient is then asked to arch or lift the chest up for thoracic extension. When doing this assessment, always start by palpating the T12, then go superiorly until you arrive at the T1 to finish all the thoracic vertebrae, as needed. Normal findings are that all the lumbar vertebrae transverse process should move forwards or become less palpable, with the ribs tilting backward. Abnormal findings to confirm the presence of T12 bilateral thoracic flexion is that both transverse processes will become more prominent as compared to the above and below vertebrae during seated thoracic extension, since the T12 facets are stuck upward and forward. For the treatment, for instance, your T12 has the bilateral thoracic flexion dysfunction, the objective is for the T12 to improve its individual extension motion, and this can be attained through a thrust manipulation. Before improving thoracic extension range, perform a gross distraction first. Patient is standing with feet separated enough that the therapist's foot can fit in between. Shoulders flexed 90 degrees, with elbows flexed such that the arms are grasped by the hands. The therapist will be standing staggered and behind the patient, right or left foot in between the patient's heels, and the hands grasping the patient's hands at the wrist. The therapist leans patient back by 15 degrees, adducts the shoulders such that the elbows and forearm are touching either side of the patient's torso for stabilization. Finally, the patient is asked to relax and lean against the therapist's chest, and a rolled towel can be placed in between the patient's back and the therapist's chest. The therapist then provides a high-velocity, low-amplitude thrust directed upwards. This can be done for 1 to 2 reps, and a gross cavitation may be felt. For the exercise, a seated thoracic extension active range of motion exercise can be done for 1 to 10 reps, progressing to 30-second hold times for 3 reps. Same with half-kneeling wall slides, since the shoulder overhead motion can also increase thoracic extension. So do you want to know how to improve thoracic forward bending motion? If so, then watch this next video. Thank you so much.